All right, let's dive into a really high yield topic for any future clinician: tuberculosis in renal transplant recipients. Now, this isn't some rare textbook only complication. It's a major cause of trouble, and it presents a huge diagnostic and therapeutic challenge that you're absolutely going to encounter. So, let's break down what you really need to know.
So here's our game plan. We're going to start by connecting the dots between TB and transplantation and really get into why the risk is so high. Then we'll look at the how, the pathophysiology of reactivation. We'll cover the atypical signs to watch for and the best ways to diagnose it. A big part of this will be tackling the central challenge, the drug interactions during treatment. It's a real balancing act. And finally, we'll wrap it all up with the essential management principles.
Okay, so let's start with the most basic question. Just how big of a deal is this really? It's so important to understand that for our renal transplant patients, the vulnerability to TB isn't just a little bit higher, it's on a whole different level.
And that's not an exaggeration at all. The intense immunosuppression that we need to use to stop the body from rejecting the new kidney, well, it fundamentally knocks out cell-mediated immunity. And that is the exact part of the immune system that's in charge of keeping Mycobacterium tuberculosis locked away. So this just creates the perfect storm for a sleeping latent infection to wake up and cause active disease.
Now, let's put a number on that risk because this is pretty staggering. In a country with a high prevalence of TB like India, the incidence after a transplant can hit 12.3%. Now, just to put that into perspective, patients on dialysis are already considered high risk, right? Well, the powerful immunosuppression after a transplant kicks that risk up even higher. This number really shows you the scale of the problem we're facing. The timing of when the TB shows up also gives us some really important clues. If you look globally, the median time is about 9 months after the transplant. But look at this. The specific drugs we use matter a lot. Powerful drugs like cyclosporine can actually speed things up, with TB appearing around 11 months. Compare that to older, less potent drugs, where it might take over 2 years. This shows you a direct link between our drug choices and the patient's TB risk.
So, that brings us to the how. How is this happening? For most of these patients, we're not dealing with a brand new infection they picked up after surgery. Nope. We're talking about the reactivation of an old, sleeping infection, like a ghost from the past coming back to haunt them. The key concept here is reactivation. The overwhelming majority of these cases, especially in places where TB is common, come from the reawakening of a latent infection. The patient probably got exposed years and years ago, and their healthy immune system built a wall around the bacteria to contain it. The problem is, the immunosuppressive drugs we give them are designed to systematically tear down those walls.
This slide just lays out that whole story perfectly. So, step 1, a person breathes in the bacteria. Step 2, a healthy immune system does its job. It builds a little fortress, a granuloma, to lock the infection away. That's the classic Gone complex you might see on a chest x-ray. But then step 3, we come along. We give them immunosuppressants to protect that new kidney. And that directly weakens the very immune cells that are guarding the fortress, which leads, of course, to step 4. The bacteria break out, start multiplying, and cause real clinical disease.
Okay, so we get the risk, we get the mechanism, but the next big challenge is actually spotting it. And this is where it gets really, really tricky. Because post-transplant TB is a master of disguise. It almost never shows up with those classic textbook symptoms.
This pie chart gives us a fantastic snapshot of what we're up against. Yeah, sure, the lungs are still the most common spot, at about a half the cases, but look at those other huge slices of the pie. Disseminated disease, meaning it spread to multiple organs, and pyrexia of unknown origin, or PUO, which is basically a persistent fever without an obvious cause. Each of those accounts for almost a fifth of all cases. That is a world away from your typical localized lung infection.
The big clinical pearl here is that you have to completely reset your expectations. If a transplant patient has a fever and you can't figure out why, TB has to be high on your list of suspects. When you look at a chest x-ray, don't go looking for those classic cavities at the top of the lungs. They're rare because the patient's immune system isn't strong enough to form them. Instead, be suspicious of disease on both sides or patches that aren't in the upper lobes. You just have to have a super high index of suspicion for TB outside the lungs.
So, given that it presents so weirdly, how do we actually confirm what we suspect? Well, our diagnostic toolkit has gotten a lot better, and it's absolutely crucial to use the right tools for this very specific group of patients. When you're screening a patient for latent TB before their transplant, this comparison is
everything. The old school PPD skin test, it's just not reliable here. For one, it can be positive if you've had the BCG vaccine. But more importantly, it depends on a strong T-cell response to work, which is exactly what these patients don't have, so you get false negatives. On the other hand, the interferon gamma release assays, or IGRAs, are way, way better. They're more specific because they don't react to the BCG vaccine, and they can pick up a T-cell response even when the immune system is suppressed.
And now we get to the absolute heart of the management problem. Once we've diagnosed active TB, how in the world do we treat it without causing the patient to reject their brand new kidney? This is a true pharmacological tightrope walk.
This brings us to the million-dollar question, and trust me, this is a favorite on board exams. Rifampicin is one of our best, most powerful anti-TB drugs. It's the backbone of standard therapy. So why do we have to avoid it in our renal transplant patients?
This quote explains the whole catastrophic mess. Rifampicin is a massive inducer of the cytochrome P450 enzyme system, specifically CYP3A4. That just so happens to be the main highway for breaking down our most important immunosuppressant drugs, like cyclosporin and tacrolimus. So rifampicin comes in and basically hits the fast-forward button on that whole system. The levels of those life-saving anti-rejection drugs plummet, and the results? They're devastating. Acute rejection in almost a third of patients, and losing the kidney completely in 1 out of 5.
So what does this mean for our treatment plan? It means we have to throw the standard playbook out the window. We have to use a modified rifampicin-sparing regimen. As you can see in this table, rifampicin is completely out. But because we're losing our most powerful drug, we have to make up for it. And how do we do that? We have to seriously extend the duration of therapy. Isoniazid and afambutyl are typically given for a full 18 months, and we often add a fluoroquinolone, like afloxacin, for the first 9 months just to give the regimen some extra firepower. Okay, let's pull all of this together. Let's consolidate everything we've talked about into the key management principles you really need to drill into your head when you're taking care of these very complex patients. Here are your major takeaways. First, treatment is a marathon, not a sprint. You need to plan for at least 18 months of therapy. Second, you have to be incredibly diligent about monitoring for drug side effects. That means checking liver function for isoniazid toxicity and watching out for vision problems from ethambutol. Third, even after that long course is done, you might need to think about secondary prophylaxis with isoniazid to prevent a relapse. And finally, always keep the growing threat of drug resistance in the back of your mind. That's a whole other level of challenge. And that leaves us with one last, really pressing question. If managing regular drug-susceptible TB is already this complicated, how are we going to handle it as multi-drug and extensively drug-resistant strains become more common? Figuring out new, effective treatments that are safe and don't have these crazy interactions with immunosuppressants, well, that's the next great frontier in protecting these incredibly vulnerable patients.